Hello, friends. I'll be giving an overview on this very important topic that generally are asked in most exams. Recently, I went for an IFCCM exam, and when a research paper is given to them in Viva, so for critically appraising an article, we do tell them what are the steps that you would look into when you're reviewing a research paper. So that's a question that would be commonly asked, and even this could be asked as an exam in DRNB, how to critically appraise an article. So it's a very broad topic. So I was asked to give a lecture on this in Ahmedabad on 13 July. So I will try to give an overview, but this has to be calibrated to the type of paper that we read because I would focus more on randomized control trial in this particular talk. The reason being the practice changing sort of a ethos that we imbibe within us or put in place are generally from evidence-based, from randomized control trial. But I'll give you a sort of a gist at the end as to what are the steps to adopt when you're reading any research paper, because there could be some steps which are little specific to meta-analysis, like how you read a forest plot. And there can be some steps which are unique to RCTs, which we'll talk about in this lecture. And there are some steps which you would possibly, or checklist you would follow when you're talking about a cohort studies or in a retrospective study. So now those things are simplified with a available checklists which are available online. You can just follow that and look into that checklist and ascertain whether the quality of an article is good and so on and so forth. So the first half of the talk, maybe the first one third of the talk would be more on context setting as to why this is important. Why this is important? Because if you look into the literature today, I mean, this is an old sort of a graphical representation. So literally you have trials. This, as I said, this data is old. 95 trials per day come out globally. And if you look at the Medline, 1,500 articles come out, are getting churned out every day. And if you look into the whole sort of a literature in the biomedical science, it's 5,000. So this is literally insane that this much of information is out there, literally coming out every day. And to try to pick and choose and stratify and distill out the core essence of good articles is an enormous task in itself. And if you look at the increase, the exponential increase in the number of articles that are coming every year. So if you see 1945 it was so less. Now if you look in 2025, so you can really see it's around 1.2 million. 1.2 to 1.4 million articles per year. So that's the sort of body of literature that is coming out in the medical science or healthcare. So when we obviously look into looking for an article or looking for an answer for a question in mind, so we have to structure the question based on what are the key components that we would look at. I'm sure this is something which every trainee should know, PICO-T, PICO-T, which is we look into the type of population that we are looking at in getting an answer for the question we have in mind. And what is the sort of intervention? PICO-T is an acronym. So intervention, what is the type of intervention that is done in that population to look for the results of the study? And, and how about this population in comparison with the control group? And the difference between the control group and the study group is what we look at comparison, which C stands for comparison, and O, of course, is outcome. So what has been the outcome following that intervention in a study group as compared to a control group? And T stands for the time. So how long the study has been conducted. So PICO-T are the key components that you would look into sort of in any research paper that you look into. These are the questions that should instantly come into your mind. So there's another acronym called IMRAD. So if for trainees in exams, we say, how do you approach? You would say, I would apply the principles of PICO-T or IMRAD. IMRAD is where introduction as to why this particular study was important and why it was needed, and what are the methods that was adopted for conducting this study and how was this study done. And R stands for results and what were the findings of that particular study that came out. And D stands for discussion. So when we say discussion, I'm sure most of you would have been reading articles. In discussion, we look into the sort of results that were synthesized from this particular study How is it in comparison to the similar studies that have happened in other parts of the world or in other places, and some take-home messages. So IMBRAD is a criteria or PICOT. So these are the broad phenomena. And as I said, if you're looking for evidence from any article, so the most importantly, you would see uh, on the type of clinical questions we ask. So what are the thoughts that you have, or what are the phenomena? For that, observational studies are good enough. So when you're looking at frequency of the problem, so how frequently a problem is occurring in a group of patients or in a population, then you take a random sample and check how frequently a problem, a disease. Like if you want to see the prevalence rate of COVID or a incidence rate, so that you look into the frequency by taking the random sample. That's what we were doing during COVID. And then diagnostically, if you have to see, does the patient have the problem? Obviously, you need to take a sample and compare with the gold standard. So when we do testing, obviously we have a reference standard and we test against the gold standard whether this particular population is having more problems as compared to another population which does not have that problem. So that is something for diagnostic problem. For prognostic, if you have to prognosticate after the disease, how long the patient survive, for that you have to do prospective cohort or follow of these patients. So those are some of the study patterns that you would look at. But if you're doing some intervention, suppose I use vitamin C in a patient or I use certain antibiotics, want to look into the outcome compared to another group which does not get that particular vitamin C or magnesium or manganese or whatever the case may be, we have to do randomized controlled trial. So these are some of the framework as to what is the question in your mind and what is the type of study that you are looking at. And the best evidence depends on the type of question. So if you look into the levels of the evidence, which we call it as a hierarchy of evidence. So if you are looking at the intervention, how the intervention has influenced the outcome. So the best evidence comes from systematic review, which we call as meta-analysis or randomized controlled trial. If you are looking at prognostication, someone having diabetes long term with some complication, long term problem you want to ascertain. So there are also systematic review and cohort studies, because cohort is a study where you follow the group of patients for a period of time to see how that problem has been progressing. And for diagnostic sort of a thing, systematic review, that's why systematic review comes at the top of the pyramid, because it applies as the reference, because it's a collation of all the studies. Because it's a collation of all studies, in hierarchically, it has a highest sort of a standing with regards to the weightage for evidence, because you look at it as a common sort of a study pattern in treatment, prognosis, or diagnosis. So other one is to look at the cross sectional. Now, if you have to look at the diagnostic, so these are some of the things. And when you look at critical appraisal of a trial, first thing is to see whether it's peer reviewed. But the whole thing is, even if it's a peer reviewed, we see some of the rubbish articles coming in so-called high impact journals. Not necessarily one can go just because it's come in high impact. The findings of the study is something that we should adopt and follow. So that is something you need to be aware. That's why it is important for every clinically and scientifically driven doctor to try to critically evaluate article, because that's what we do when you look at our JIC's rapid journal review. We critically dissect out and we see many of the articles have no relevance to our clinical practice. It may be NEJM, it may be in Lancet. Just because it has come there, not necessarily we take it on the face value and we adopt it in our clinical practice. We dissect it out. Yesterday, we dissected a journal on ringer lactate that came in NEJM versus normal saline, and I felt it was of no relevance. Why? Because we are able to critically appraise that article and say it has no value to our practice. So that's why we look into bias, we look at confounding, and we put it in the trash. So this is how we look at it. That's why it is important that you are able to critically evaluate an article. And most importantly, that article may have been done in Chinese population or in a European population. Not necessarily it may have any impact on the type of population that I am dealing with. So that is also important. But the best research evidence as a benchmark has to be customized and calibrated to the type of patients we are seeing, the type of patients, the type of genetic background the patients may have, and we have to titrate it to the past medical history the patients may have, the nutritional sort of a status of the patient, and the psychosocial behavior of the patient and preferences. So there are a lot of variables which influence the applicability of a study that you look at in certain population to the type of patients that you are seeing. I think that is what you need to get in mind. So that's why we adopt sound principles of evidence-based medicine. So just for all our trainees, apart from evidence-based medicine, for me, who is scientifically driven, there's no other sort of a thing that we should adopt to. Obviously, when we talk about evidence-based medicine, the mother of evidence comes from randomized controlled trials, because that is what gives you some practical relevance to the type of interventions that we may wish to adopt. So if you do not adopt to this, the type of practices, clinicians practices, all these other means and ways, which is not the way that we should practice medicine, which is eminence, which is someone who is senior. He says, out of my practice, I've seen this many patients. You give this, it is going to help. So this is eminence based. Or someone, sometimes, many times, you would see someone who speaks very nicely and tries to convince you about the type of practices they do. And in many professorial sort of institutes where there are vehemence that is shown, which means they show their sort put forth their point of view with vehemence and not necessarily it may be evidence based. And someone may attribute most of their practice patterns to the religious belief systems or diffidence, and many of them may follow the type of medicine fearing the litigations that may happen, which is nervousness, or someone may just be doing confidently with lot of ignorance that may be there. So these are the different practices that prevail in any healthcare system. That one system that we need to firmly adhere to and adopt to is the evidence-based medicine, which predominantly gets distilled out from good sort of a trials and studies that have been done in a population. So this is just to showcase as to the different types of practice patterns clinicians adopt, and not necessarily everyone may be adopting to a sound evidence-based medicine. And if you look hierarchically, the type of studies, so it starts from hypothetical standpoint, which is from the animal studies. Then it goes on to observational studies, which is cohort, case control, or cross-sectional. Then the interventional studies, which is randomized trials, from where we try to synthesize and distill out the essence in our practice pattern. And culmination of these or combination of these, we put it into meta-analysis or systematic review. So this is the hierarchical sort of an approach to the weightage we give to the different evidence that becomes available. So now we'll just jump into when we interpret any sort of a study, where this particular talk focus will be more on RCT, because they are the ones which hold relevance to us with regard to the practices that we adopt in our daily clinical use. So when you talk about randomized controlled trials, first thing is you should ask yourself whether it is answering the question that you have in mind, and you have to look into the validity of the RCT, whether the study is relevant to the type of population that you are treating. So you have to look at the internal validity and the external validity. And then the third thing that you need to do when you are looking into RCT is the PICO. What is PICO? Which is, again, you have to look at the population it is done, the type of intervention, comparison, outcome, and the timelines it is looked at. And when you're looking at a study, you have to see whether it's a single center or it is a multi-center, because multi-center studies get more weightage. And then you have to always look at the funding of the study, whether the funding is coming from the institutional funding or there is a sponsor, because sponsor may have influence or may put in the bias into the outcome of the study, and the type of data analysis that the people have put in place and the statistical analysis that they have adopted. And I think the take-home message for you is now the critical appraisal of all the studies for all the future researchers and intensivists is there are ready-made sort of a checklist which come under this dimension of critical appraisal skills program, where they have devised very standardized checklist for each type of the study, and we'll go through different components for each different types of studies that you may do. But this in this particular talk, I'll talk on what are the checklists that you need to look at. There is 10-point checklist for RCTs. Most of the checklists are around 10 checkpoints, where you need to just look into the checklist and see whether the study that you're reviewing is conferring to all these 10 checklists. That's what we will look into. And as I said, the first sort of a question in the critical appraisal skills program is, did the study address a clearly formulated research question? So that is the first question. The first question you need to ask whether it's answering the question that you have in mind. For that, you have to just simply put PICO and see whether the population is right, whether the intervention that they've done is right, whether they've compared equally, and outcome. So yes or no. So that is the first question in the case. The second question is, was the assignment of participants to interventions randomized? So I'll talk a bit on types of randomizations. When we talk about randomizations, one needs to ask how was randomization was that? Whether it was a sequential randomization, simple randomization, whether it's a block randomization, whether it's a stratified randomization. So these are the questions we ask in exams. So what are the different types of randomizations? How was the randomization done? And whether there was a sufficient, the question has to be whether there was sufficient number of patients that were taken into account for randomization, and was that randomization sufficient for getting that type of results that you are looking into, and whether there was a bias in randomization. That is the thing that will influence the outcome. So whether there was any bias, and we'll talk about bias. These are the two things I'll talk, types of randomization and the bias, which will influence the outcome of the study. And then the third important thing, whether there was adequate blinding. So in exam, recently in exam, we asked at least all the candidates, what are the types of blinding? Many people wouldn't answer it very well, because you ask what is single blinding, double blinding, what is triple blinding, and many possibly wouldn't answer what is triple blinding. So you need to know what are the types of blinding that was adopted. So that's the second question. How was the randomization? So the third question is, were all participants who entered the study accounted for at its conclusions? Okay, so this is intention to treat analysis. This is very important. We ask in exams, what is intention to treat? So you have to look into the population and see whether any patients were lost to the follow-up. If they were lost to the follow-up, whether they were taken for analysis of the study. That is intention to treat. You have to go read about it. We ask in the exam. And whether there was intention to treat of all the patients. This is very important questions you need to ask whenever you're looking at any RCTs in any sort of a good article. And third most important, to see whether the study was stopped preemptively for whatever reason, because that has a huge bearing on the type of conclusions that we make. Because the yesterday's discussion we did in NEJM, ringer lactate versus saline. So the study was stopped preemptively. So we need to know why it was stopped preemptively. So there are many studies that get stopped preemptively. Or is it out of benefit, or is it out of the harm that it is causing to the patients? So these are the three questions you need to ask, and these are all there in the checklist. And this makes, if you answer this checklist, you know how critically you have evaluated the study. And the fourth questions we need to ask, which comes in section B, is, were the participants blind to interventions? When we say single blinded, the person who is doing the study may be blinded, or the patients, the study population may be blinded. What is triple blinded? Triple blinding is where the people who are analyzing the results of the study are also blinded. So that is called triple blinding. So this is what we ask in the exam, and no one answers. Were the investigators blind? See, one thing is, were the participants blind? Were the investigators blind? And the third is, were the people analyzing the outcomes blinded? So this is triple blinding. So whether it was single blinding, double blinding, or triple blinding is the fourth question that you need to ask. The fifth question is, were the study groups similar at the start of the randomized control study? Which means whether the population, the intervention arm and the control arm, whether they're properly matched, whether they're similar to each other. Because if they're hugely different, if the control population and the intervention population are very different, obviously the results will be skewed. That is also an important question. Were the study groups similar at the start, and were they equally randomized, and was there a good matching? If you look at any NHM article, there will be baseline characteristics, and they would have matched in the control group and the treatment arm. So that is something very important to look at. The sixth question that you need to ask is, apart from the experimental intervention, did each study group receive the same level of care? This is very important, because when you're doing randomization, why do we blind? Because the level of care should be same in both groups. Because if you're not blinded, there'll be a bias that you may be giving a better care to the intervention group as opposed to the control group. And that is something you need to find out, whether both groups, treatment arm and the control arm, the treatment received apart from the intervention were the same. Intervention is different, but all the other things have to be same in both groups, and whether they were follow-up intervals also have to be similar. Even placebo have to be followed for 180 days or 1 year follow-up, whatever has been determined has to be adopted in both population group is what is emphasized. Then the seventh question, which is section C, is were the effect of intervention reported comprehensively. So we go into the results. Whether they were, when we talk about results, in your RCTs, you have to see whether the study was adequately powered to answer the questions that you have put in mind, and whether the outcome that was sort of hypothesized or the outcomes that was meant to be looked at was looked at the end of the study, and whether the outcomes, whether the binary outcomes and the absolute effects both were looked. Each follow-up of this has to be done, and in each study group, binary outcome or absolute effects were looked at is something that has to be looked at. And questions have to ask whether there was any missing data or dropouts were there, because there are many trials. There was one vitamin C trial where there was a lot of missing data present. So obviously that was cited as a huge limitation. So there can be missing data. Even activated protein C, the landmark trial that came, there was missing data. And whether there were any biases in the study. And we'll talk about different biases, and whether the statistical tools adopted for interpreting the results were they adequate and were they robust enough, and whether the p-values were mentioned in the study for all the different comparisons that were. So these are some of the um, seven sort of elements that you should look when you are looking at the results component. So whether the power was adequate, whether the outcome that was expected was looked at, whether absolute effects and the binary outcomes, each one of them was looked at, whether missing data, whether or biases, statistics, and p-values. So this is something you have to remember. And was the precision of the treatment effect reported for this whether confidence? If you see any good randomized controlled trials that come in, it's not only p-value, there is always a mention of the of the confidence interval to look at the distribution pattern and the significance of the deviance that happens. So it is important. And if you see any NEJM recent articles, there'll be always a forest plot with confidence intervals that will be showcased in different subgroups of the patients. And the ninth question that one needs to ask is, do the benefits of the experimental intervention outweigh the harms and costs? So this is the risk-benefit balance that if study has looked into the risk-benefit balance and the cost-benefit analysis was done. So one has to look into the size of the intervention and what is the treatment effect of the intervention that was put in place, whether that intervention caused any harm. If you look at any trial, you would see there is adverse effects reported and that is given weightage, and whether it was cost effective. So these three questions also have to be asked to look into the validity of the study or the strength of the study. And the last questions in this particular CASP is can the results be applied to your population or to your context? So one has to see whether the study population that, like yesterday, the type of trial that we looked into, or let's look into a trial where there was a fish trial done in African kids. So we don't know whether that group of population are comparable to the type of patients we deal with in India. So yesterday the ringer lactate study that we looked into, also we weren't sure whether that study group was in comparison, because that was a Caucasian population, whether it was comparable to our group of patients here, because that was done in Canadian group of patients. We don't know whether that is applicable. So those are the questions that one should mind. And one should see whether the difference in the study population and the population that we build. So the study done in Canadian population compared to the Indian population, whether the differences that exist have any bearing on the outcome that they have looked at is something that we need to look at. And whether the difference in outcome is important to our patients is what that study should answer. So these are the 10 questions that CASP has put in place. And this CASP, you can just Google and you will get CASP checklist for RCTs, CASP checklist for meta-analysis, CASP checklist for cohort studies, CASP checklist for retrospective. So you don't need to memorize, you just download the CASP checklist. And but one should know what are the contents of the questions that you need to ask. And these are the questions, if you ask, you would have very well critically appraised the study. So we'll just very briefly, for all our trainees benefit, talk about randomization, because we're talking about RCTs. So simple randomization is where you in some format you randomize the patients. So you take a single sequence and do a random assignment. But there is problem with this simple randomization, especially with small sample size, but you may miss out on equal distribution of the patients with this simple randomization. So what is emphasized is more of block randomization, where block randomization, you take one population and divide the similar characteristics one into treatment group and the control group, where there is a good matching. between the treatment and control group, and the sample sizes are equal, generally meant to be equal in treatment and control group, and ensures there is a equal balance and there is no selection bias in this sort of a block randomization. It is useful in small studies because the population is equally distributed between the treatment arm and control, which does not happen in simple randomization. And block randomization is always either two block randomization, it's in even numbers, two block, four block, six block, so on and so forth. But generally, two block or four block randomization is what you would commonly encounter. Then there is something called stratified block randomization, where you take one big population, divide them into two, and then subdivide based on certain characteristics. That we call it as stratum. We further stratify. Suppose you have divided the whole population into two groups as a block randomization. Each one, you divide them again by age, comorbidities, sex of the patients, or the medications they're on, and you divide into subgroups, which we call it as stratum. So this is stratified block randomization. It controls and balances influence of covariates, like I said, age, disease severity, so on and so forth. Then there's something called adaptive randomization. So this we tend to do this adaptive randomization in certain drugs that you may be using for the patients in different dosages. Like if you see, this generally happens if you are using some antibiotic in three different doses. We don't know whether 500 mg is more effective, 1000 mg is more effective, or 1500 mg. So you give three doses to three different subgroups of patients with different body weights, so on and so forth. This is called adaptive. We adapt to the patient's needs based on the weight and stratify them and then analyze. So this we call it as dynamic random adaptive randomization. Then these are inappropriate. Many of the trainees, when you do randomization, will say alternate patients we take, like you here you have done alternatively, one patient into the experimental group, one into the control group. So this is not the ideal randomization that one should do. And even it is suggested that one cannot do, so sometimes you can do a study where I'll say first 15 days of a month, I'll put them in one group. The second 15 days of the group, I put in the second group. So these are all inappropriate randomization. So you can't do randomization based on date of birth, date of admission, date of discharge, day of a week. So these are all considered inappropriate because the distribution of the population can be erratic and it can introduce biases in the type of study. So I will talk about biases. So biases is the variables that influence the results in a erroneous way is called the bias. It can be selection bias, performance bias, detection bias, laboratory bias, or sample size bias. So simple selection bias. If you say sequential patients, one after another, or you take 3 days in a week, we put in one group, and 3 days of the week we put in another group. So you have a distribution of population like this. This is the entire population, but the data you have used is this. So we have seen sometimes the weather changes, we may get more flu patients in certain period. So here, if you see, the distribution is not normal because you have missed out on all these other elements in the other population. So the distribution is skewed. So this is selection bias, or there is performance bias. Performance bias is where you are not blinded. Suppose in ICU, I am doing a study between RL or NS, and you want to skew the results. So obviously there may be a patient who is in control group. This is not in ICU, maybe in OPD. If suppose someone is getting a intervention drug, they may be more satisfied and outcomes may be influenced, and the control group may be disappointed and may behave differently. So this performance bias, especially if you are doing on a OPD basis, you are testing some drug for pulmonary hypertension or so on and so forth. If patient realizes that they've got a test drug as opposed to the placebo, so they may behave differently. So this is called performance bias. And detection bias is where blinding is not adequate. Somewhere the investigator is aware the type of drug that is being used. He may say it is blinded, but he is aware that this is RL that is using as opposed to the saline, and he may behave differently. So this is detection bias. Or laboratory bias, where where the laboratory personnel who is doing the study may influence the results to favor the outcome of the study. So this is laboratory bias. So bias in the way test is run, interpreted, or retested. Then there is a sample size bias. So where if you have too much heterogeneity of the patients, so if you have homogeneous, it's very easy. If you have heterogeneous patients of this nature, where I've just put different, so that also has a bearing, especially if in insufficiently large sample size, imprecise estimates may come and results may be showing downward. So these are some of the biases that can exist. So basically, in this whole narrative, I've given you an overview of how important it is to adhere to the sound principles of evidence-based medicine and what are the key ingredients that we need to look into when you're analyzing, critically evaluating an article. More so, I focused on randomized control trial because those are the trials as intensivists that we would be looking into to influence our practice. So you can adopt your CASP, and of course, you need to know PICO and MR, and you follow the checklist, and those checklists pretty much have. And we spoke about the types of randomization and the type of biases that we should be able to appreciate. So, summing up, critical appraisal of an article is a systematic process to look into the strength and weakness of the research paper. So, that is the critical. When we give you an appraisal in an exam, this is what we are meant you to go through. Systematically evaluate the strength of the study, weakness of the study, and critical appraisal we do to see whether we can adopt the findings of this study to our clinical decision making and apply the results to our clinical practice. That's why we discuss the journal articles and to see whether this has any bearing on change of certain practices that we do in our ICU. And different study designs are prone for systematic bias because every study will have certain biases that you should be able to appreciate. And it is suggested at this point of time to follow checklists when you are critically appraising an article. So adhere to the CASP checklists, which are very robust, and there are checklists for each type of the studies that we do. So checklists are useful to ascertain the strengths of the study. The other factors that tend to influence is whether the research question was right. The first thing that you should do when you're looking at an article is whether the question they have asked is the right question that they've asked, and the type of statistical tools they have used to analyze the data, the type of conclusions, whether there was legitimate conclusions that were made following the study that was conducted, and most importantly, look into the conflict of interest, whether who has funded that study. If that study is funded by an experimental drug that is in question, so one needs to exercise caution how you would take the results of the study on the face value. So that's about it, friends. So that's about the content that we have as to how we critically evaluate. I've pretty much covered most of the components. There are certain elements which may change when you're looking to meta-analysis. There is a separate video I've done on how to interpret forest plot. You can go and see that. And when you're looking at cohort studies, what are the few nuances? I may cover in subsequent video on prospective cohort and retrospective. What are the nitty-gritties that one needs to look at? But most of us read RCTs. Any good RCTs come on a regular basis, so it is prudent and imperative that this talk becomes more relevant. So thank you, friends. Request you all to submit your valuable work to Journal of Acute Care, and of course, you can visit my website to refer to this. Thank you. Thank you, Manipal.